until they say I don't, I want to make sure that I'm not creating a second problem. Vital signs, if I can get them. I came upon this head injury. I don't have my sphygmomanometer or my stethoscope. Can I still check some of my vital signs?
Yes.
I can still check respirations. I can still make sure they have some sort of pulse. And I can tell if they have a temperature change from head to toe just by touching them. Glasgow Coma scale. Remember that? Yeah, you're going to see that every semester. I promise you, between now and level 4 and your NCLEX. So, Glasgow Coma scale. What's it monitoring? Eye opening, my response, can I follow commands, and my verbal response. Am I speaking coherently, or am I confused, or am I not able to speak at all? Scores, 3 to 15. So what's the lowest score I can get?
3.
3, even if I'm dead. 15 is the best score. So my patient has the best outcomes the higher my Glasgow Coma score is. Can a patient who has a Glasgow Coma score of 6 recover?
Yes.
Mm-hmm. Yeah, depending on the situation and the interventions that we provide, they can recover. So, be familiar with the Glasgow Coma scale. You know in level 2 we went over 100 scenarios on how to calculate that out. Be familiar with that. All of this stuff should be just a review. Pupils. Is that part of your Glasgow Coma scale?
Yes.
Is it?
No.
It's not part of Glasgow Coma, but does it give you valuable information?
Yes.
Yes. So they usually do it in conjunction with the Glasgow Coma scale. How do I do this?
With a pen light.
With the pen light, not my mega flashlight. If I'm in the hospital and I can dim the lights first, I can get a better pupil response when the light shines in their eyes. Is everybody's pupils equal?
No.
Is that good information to know before?
Yeah.
Yes, if you can know that on admission and have it documented that the patient's left pupil is 1 millimeter larger than the right, then the next person who checks it doesn't freak out because they're not equal. So it's good information to know up front. You can't see the slide very well. Sorry about that. Your head injuries. Okay, so when your patient has a head injuries, you ever been hit in the head?
Yep.
What do you feel like?
Crap.
Okay, crap. It does hurt. Yes. When you felt dizzy. When someone says they saw stars, is that true?
Yes.
Yeah, you literally can see light flashing. You know, might not be stars, but light flashing. How about nausea and vomiting?
No.
So even if your patient had a migraine, can they have nausea and vomiting?
Oh, yeah.
So if I have a migraine or if I'm whacked on the head, I can have nausea and vomiting. Can my vision change?
Yep.
Yeah, I can have blurry vision, or I might have double vision for a period of time. Balance. You just got whacked on the head. You think you might be staggering for a minute? So all of these are your symptoms of a mild to moderate traumatic brain injury. Okay? We want to prevent them from getting worse because we don't want to have the patient yet that we're going to have in level 4 because we're not ready for that yet. So we need to prevent increases in intracranial pressure with the nursing interventions that we can use here. One of the important things is right here, sleep habits. Patients with head injuries have a change in their sleep habits. Some of them want to sleep all the time, and some of them can't rest. So you just need to be aware of that. Because rest is important for healing. And what happens to your patient if they're awake for hours and hours and hours on end?
They get delirious.
They really do become delirious. And they call it ICU psychosis when the patients are in ICU and they don't sleep for days on end because it's never quiet. It's a real thing. So rest is super important for these patients. Personality changes. Where would my injury be? Frontal. I hit my head on the dashboard of my car when someone rear-ended me. What other things might happen with a frontal lobe injury?
Break your nose. When you break your nose, that's worse.
No, raccoon eyes don't come from that fracture. They come from a different fracture. We're going to talk about it.
I think the behavior is like impulsive.
Okay, impulsive behavior, for one. What about memory problems?
Yeah.
Short-term memory problems, judgment. Their judgment may be impaired. Someone who has a frontal lobe injury, particularly like a blast injury, who is always mellow and on top of things and stuff, can be real temperamental and forgetful and a total personality change for the family. You think that's hard on the family? Mm-hmm. Yeah. How long can it persist? Forever. It can last forever. It can last for a long, long time. So you have to learn how to build in coping mechanisms so that the family can learn to deal with whatever deficits the patient now has. Here's our slide that has some signs that we're looking for after. We don't want to see this change in level of consciousness with the drowsiness, because if they're sleeping, I'm just going to tell you a story. This has nothing to do with the head injury, but a diabetic patient. And my friend had this patient, and she kept walking by the room, and she's like, oh, they're being so good, they're sleeping tonight, you know. And she thought they were just fantastic that this patient who was causing problems the night before was sleeping. Well, he was sleeping, y'all, because his blood sugar was 36.
Oh,
you know? She didn't even think to go check on that. So do I really want my head injury patient sound asleep all the time?
No.
Even if I'm letting them rest, I still need to, hey, you okay? You need anything? Wake them up just to make sure that they're still coherent and the Glasgow Coma scale hasn't changed.
So you
Blurred
wake them
vision.
up, like, just randomly? You just wake them up? Okay.
When you work night shifts at the hospital, I know you probably have this illusion that people sleep. That is not true. They don't. Anybody who's ever worked a night shift knows that's not true. And the hospital ain't a hotel anyway. So I want you to rest, but I still have to do my job to take care of you. So here's just a picture with our signs and symptoms of the head injury. First 24 hours, I really want to be on top of them, watching them. You know this if you had a kid and your kid got hit with a baseball in a baseball game,
Right.
or fell off the swing set or something. You're not going to just let them be unmonitored for hours on end. You're going to keep checking on them to make sure there's no change. This is the fracture I want you to know about in here. It's a basilar skull fracture, and it has specific things associated with it that you need to know about. It involves the floor of the skull, and the fracture is actually back here along the base of the skull. And it causes battle sign. This is battle sign right here. This bruising behind the ear, and you can see they have blood in their ear. This is the raccoon eyes, the big swollen and black and blue on both eyes. What is rhinorrhea? Runny nose. And in this instant, if my patient keeps complaining of this, my nose is running, you need to make sure it's not cerebral spinal fluid. Okay? So the way you do that is just on a white tissue or a white 2x2, 4x4. You let it drip on there and you'll see the halo. There will be a blood circulation in the middle, and then it'll fan out and make the cerebral spinal fluid. It's called halo sign. So that's your halo.
Interesting.
Rhinorrhea. What is rhinorrhea? From your ear. So my patient has cerebral well, you can see the blood in their ear, but they have cerebral spinal fluid leaking from their ear. Do I want to do anything to stop that?
No.
Like, you know, when you have a bloody nose and you go into the ER, what are they going to do for you? They're going to put the tampons up your nose and stop the bleeding. But this, you don't want to do that. You don't want to try to stop it by putting something in the nose or the ear to stop it.
What if it's excessive?
You need to notify the physician, but they're not going to try to stop it. They'll just put the little mustache underneath there, the gauze mustache, and let it drip.
That's something you notify the physician for.
Here's the thing. If cerebral spinal fluid can leak out of their nose and their ears, what can get in? Bacteria. So this patient's at a higher risk for meningitis, because once the bacteria enters that cerebral spinal fluid and irritates those meninges, they're at a risk of infection. Or an abscess. Once an infection gets in your cerebral spinal fluid in your brain, you can form an abscess. The other thing, cerebral nerve palsy. All those cranial nerves that are running right here in the back of your skull can be affected by that. So cranial nerve number 3 for sure. Which one is that? Well, okay, 2, 3, and 5.
That's your facial nerves.
Your facial nerves, your eyes, so all of those. Loss of hearing. Which cranial nerve is that? 8. So those are the things that you need to be aware of. Remember that picture we had with the numbers? What was it with? It was with acoustic neuroma. Your cranial nerves are on there. But on here, it affects your eyes, it affects your hearing, your facial nerve. And so you're watching for any changes in that when you're assessing the patient. We want to prevent secondary complications with our head injuries, okay? So the main way to do that is to monitor your patient for changes and make adjustments as necessary, okay? Because early detection is going to help your patient. What happens if your patient starts having increased intracranial pressure and you miss it?
Hold on.
It ain't going to go down by itself. So if you didn't do something to help lower the intracranial pressure, it's going to keep rising. And the longer it gets higher, the more deficit your patient's going to have. So early detection is the key. This is a whole bunch of goop for nothing, but let me tell you what it is. If I have my primary trauma, where I have my primary head injury right there, I can have damage to the blood vessels, okay? Or I can have damage to the actual tissue. I can have a tumor growing in there. I can have a bleed in the brain tissue. Then, right here, I have my break in the blood-brain barrier, because if cerebral spinal fluid is getting out, things can get in. I have bleeding, I have swelling, and I have no blood flow. What's going to happen to the tissue?
It's going to die.
Great big word right there for dead brain tissue. Yep. That means there's no circulation to your brain tissue. So that's what we're trying to prevent by monitoring our patient and doing what we need to do. Here's some of our secondary head injuries. So an epidural hematoma is what kind of blood right here? Arterial. How does this happen? Fast or slow? Fast. Arterial bleeding happens fast. So when my patient got hit on the head, they have an arterial bleed, they come to the ER, we do the CAT scan, we're going to see it. If, however, they have the subdural hematoma, this is venous bleeding. It can be a lot slower. So we didn't see anything on the CT scan, and we sent Grandma home, and 6-7 days later, there's changes in Grandma's cognition, in Grandma's reaction. She's less alert. And they bring her back to the emergency room because something's changed. We do another CT scan, you're going to see this one. This is the most deadly bleed that you can have. This one we can do something about early. This one is harder to detect because it's slower onset. If it's slower onset, how are your symptoms? Fast or slow? Slow. So it could be happening, but you're not seeing it, especially if you took your mom or grandma home and you don't really know what you're looking for, and then all of a sudden 6 or 7 days later you see a big change. So this subdural hematoma has the highest mortality rate.
Yeah.
For patients.
Yeah, last semester that happened to a patient. She fell off a ladder at home, and I guess nothing happened until later, and she was in ICU.
I've only ever seen one person recover from, like, an older lady, and she was so old, she was in her 90s, that her brain tissue had shrunk so much that she could accommodate the bleed. Then the bleed stopped and it started resolving, and she went from being almost in a coma to being perfectly the way she was before. But I've only ever seen one person. On the venous?
Yeah, the subdural hematoma.
They usually do it on the epidural hematomas. So, hydrocephalus, you know what that is?
Water on the brain.
Water on the brain. Why? I'll just tell you this. I have a niece, her name is Abby. She's 2. She has hydrocephalus. I knew that since the very first picture I saw. But nobody else in the family seemed to pick up on it. She's 2 now. She's starting to have some neurological symptoms. So why would she have symptoms now when she didn't have symptoms before?
It's building up.
She grew. Her brain got big. So it doesn't have enough room for everything else that's
Okay, right, that's what happened. As the sutures started to close and the fontanelle closed up, she has nowhere for all the extra fluid to go now. So now she's starting to have some neurological symptoms and they're going to put a shunt in. This does happen sometimes in head injury patients too. Brain herniation. What's your brainstem do? What's it responsible for? Breathing. Blood pressure. Heart rate.
Temperature.
Kind of important. So if I have all this pressure and it shoves my brainstem down into my spinal cord, is that good or bad? Bad. It's bad. Is that reversible or not reversible? It's really not reversible. Like once that damage occurs, it happens so quickly that you don't make a good recovery from that. And then here's, go ahead.
What causes what?
The increased intracranial pressure
So from-
has nowhere to go except down your
So
spine.
from the hydrocephalus, you can.
No, these are all separate.
Okay.
They're all separate injuries you can have. Secondary injuries.
Okay, I see.
She said the tibial and the sutures.
Infection. You can have infection of the meninges, or on this one, they actually have an abscess in there. So you can have like a pocket of the infection. Is this supposed to be there? No. What's it doing to your brain tissue?
Pushing down on it.
It's pushing it out of the way, so you're going to have increased intracranial pressure right there. So those are all the things we're trying to prevent from happening to our patient. Intracranial pressure, we're going to talk a little bit about it in here. It's really a level 4. We get into a lot of it. Normal intracranial pressure is 10 to 15. And the way they measure that is by putting in a ventriculostomy and hooking it up to a monitor. There's no way to walk around and say, well, your intracranial pressure is 13. Yours is 11. You have to actually have a probe into their brain that's hooked up to a machine that tells you the pressure. But normal is 10 to 15. It is the leading cause of death in patients who come to the hospital with a head injury. They get there and it's not treated, and the intracranial pressure is what kills them. It's controlled, and this is what we're going to talk about in level 4, so please don't get lost in this. It's controlled by doing 2 things: controlling the patient's blood pressure and controlling the ICP. So they can use that drain to drain off cerebral spinal fluid into a bag, because if I can decrease the amount of cerebral spinal fluid you have, I can open up space for the bleeding or the swelling or whatever else is going on. Cerebral pressure perfusion is the amount of blood that's perfusing your brain. That's the most important thing. Who was it who had the patient with the cerebral? Was that you? Yeah. That's the most important thing, is this cerebral pressure perfusion. How much, I can have a good blood pressure, but if I have a high intracranial pressure, am I perfusing my brain? No, there's no way for it to go. So the pressure gradient over which the brain is perfused, and the number I want you to remember is 70 millimeters of mercury. That's what we want it to be. And I don't think I gave you a calculation in here, but I'll tell you how to calculate it. You take your MAP, which is your mean arterial pressure, which I know you probably know how to calculate, am I right?
Systolic was systolic divided by 30.
I'm not going to ask you that question until level 4 though. But you have to calculate out the MAP, and then I would give you the ICP, and you subtract the ICP from the MAP to tell you what this number is. So if this number is 55, if I say on a test question the patient has the client has a cerebral perfusion pressure of 55, are they perfusing their brain?
No.
No. If I say it's 72, are we okay?
Yes.
Right. I want it to be 70-ish or higher. Well, there's a reason I don't want to be too high, but it can be over 70 a little bit. So you don't have to know how to calculate it. You just need to understand this is how I'm measuring how much blood is getting to my brain tissue. And remember when Ms. Cooper talked about hearts and she said that when there's some sort of blockage or I have no blood flow to my heart, I'm causing ischemia. Time is of the essence. It's the same thing with your brain tissue. If I'm not getting perfusion to the brain tissue, I'm killing brain cells. So perfusion is a big deal. Let's see. Here's our early signs of intracranial pressure. Changes in LOC. What kind of changes? What am I looking for? Decreased, but what am I looking for?
Confusion.
They might be confused.
Dizziness.
They knew they were in the hospital this morning, but now this afternoon we're at the mall.
They're gonna be tired.
Balance issues, maybe?
No, not early. Early.
Oh, okay.
Early. Yeah, they might say things that, like, they might have had a conversation with you in the morning that made total sense, but now we're having a conversation and it really doesn't make sense anymore, or fit the conversation. Restlessness is the most common early sign of level of consciousness change. Your patient was perfectly content this morning, and now when you go in there, they're restless in the bed. You can't really quite put your finger on what's going on, but something's happening. It could be hypoxia. So I would want to check a pulse ox for sure, because if they're hypoxic, they're going to be restless. Like if you can't get enough oxygen, you get a little restless. But level of consciousness is restlessness is the number one sign. Papal edema, that's a swelling behind the eye that makes their eyes look kind of bulgy. Not like hyperthyroid eyes, but bulgy. Then we have the sensory motor changes that she was talking about. Increased temperature. Why would I have an increased temperature, do you think? Well, I'm pressing on the hypothalamus and causing changes in my temperature.
Yes, yeah.
But if my patient has a fever, what's that doing to my intracranial pressure?
Increase.
It's making it be higher. Because the higher my temperature is, the more the metabolic needs of my body are. These are late signs over here, right here. Increased blood pressure, decreased pulse, and a change in respiratory pattern. So if I go into my patient's room and all of a sudden they're like, am I late? Yeah. I missed something a couple hours ago on my assessment. If their blood pressure, especially their systolic blood pressure, is getting higher and their pulse is decreasing, I missed something early on. So when I'm assessing my patient, I also have to make sure that I'm assessing their vital signs. So not just their Glasgow Coma scale, but I want to see the trend if their blood pressure was 130 over 70, and now it's 148 over 64, and now it's 154 over 52. I want to see that blood pressure change. And if I'm looking at that, I'm going to see a trend. I don't know if you can do it in the hospital on the computer. Who works in the hospital? Can you hit a trend and see your trends on the vital signs? So you can, like, instead of looking at numbers, you can actually see the trend. Yeah, we used to actually have to graph it out on our neuro patients and so the doctors could see it. But if I get to here, this is called Cushing's triad. My patient's going to the ICU because I missed something. You know? What kind of things do you think I want to do to decrease intracranial pressure? Okay, I want to control their blood pressure for one, but I don't want their blood pressure being too low because I still have to perfuse their brain. So I want to control it, but I don't want it to be too low. What else? Simple things, nursing things. Set them up. How high do I want to set them up? 30. 30 degrees is the magic number. Now, not everybody's going to be the same, but I want to set them up high enough to decrease the pressure, but low enough to still perfuse their brain. So it's going to be individualized for my patient where the head of the bed needs to be to get the best result. What else do you think I need to do?
Nothing invasive, like no Foley or anything.
Okay, why?
The increases, because they bear down and that increase.
They bear down, they get anxious, it increases intracranial pressure. So unless there's an absolute need to do something invasive, I don't want to do that. What else?
Did she say decrease?
Say it again.
If you're doing some activity.
Yeah, but you don't want it to.
Okay, if I'm doing something, I have them exhale when I'm doing it instead of holding their breath. What happens when you hold your breath?
Increase pressure.
You can vagal down and decrease your pulse rate. What were you saying? Stool softener for that very reason. Because when my patient has a head injury, I do not want them sitting on the bedside commode or the bedpan or whatever, constipated, struggling to have a bowel movement.
Or they sneeze.
So anything like that, like we learned with the eyes, if you sneeze, open through your mouth. What about clustering care?
Yeah.
I don't cluster this person's care. You'll never hear me say that about any other patient. This patient, I can only go in there and do what I need to do, let them have a break, go do something else, and I'll come back. So I'm not going to go in there with all of my stuff to give them all their pills and give them their bath and change their bed and suction their trach and do all that stuff at one time. I'm going to scatter their care throughout the day, okay? What about noxious stimuli? What can be considered noxious stimuli in the hospital?
IV pumps.
Okay, the IV pump sounding all the time. It's annoying to me and I don't have a head injury. Family and visitors. Can family be super stressful? Yeah. Even if your patient is not conscious, family can really stress them out. What about if my patient does have a trach? Do I suction them?
I mean,
I suction them if they need it. Because every time, who has suctioned a real trach, not just in the lab? Anybody? Every time you go down the trach and you put your finger on the suction, what does your patient do? What does that do to your intracranial pressure?
increase it.
I'm increasing it. So I only want to suction them for ventilation. Not just because it's really fun, because it is. You don't want to do it because of that. Just because your doctor has it ordered 4 hours and you went and assessed your patient, his lung sounds are clear, he's not blowing bubbles out of his trach, there's no need for you to suction him. Now if I go in there in a couple hours and he's struggling and I need to suction him, I'm going to, but only PRN. The other thing your book says, you know how the bed, you know how you go in there and you pull your 300-pound patient up to the head of the bed. And the first thing I do is I hit the button at the foot to put that little knee gatch in there so that I don't come back in 10 minutes and he's all the way at the bottom again. What does that do to circulation if I have that little knee gatch? It prevents it. Oh, I didn't mean to do that. It doesn't let them have good circulation. So I want to prevent that. And that being said, what happens when you go in there, your patient has increased intracranial pressure, and they're like this. How do I want their head to be? Up and midline to promote drainage as best I can. It's not going to solve the problem, but I want to promote it as best I can. The other thing is administer mannitol. What do you remember about mannitol?
The osmotic.
Diuretic. Osmotic. What does that mean, osmotic? It pulls the fluid out of the cells, including your brain tissue, into the vascular system, and then you excrete it through what? In your urine. Hopefully in your urine. So what am I checking when I walk past my patient's room?
Urine output.
Urine output. I don't see any.
Lung sounds, then you need to stop or you need to go.
Right. I need to stop what I'm doing. I need to check on my patient first. Then I need to go to my technician and say, did you empty my Foley catheter and not write it down? Because there's nothing in my Foley bag. Before I freak out and call the doctor and say, oh my God, they're not putting out any urine. Well, when was their Foley emptied last? And you have no clue. So get your facts all in order first. But I want, and there's no urine, there really truly is none. Then I really am concerned about my lung sounds. Because if I'm not excreting all that fluid through my kidneys, that's backing up somewhere and usually it's going to create pulmonary edema. So I want you to know how mannitol works and what things I need to do to assess my patient and keep them safe. Then this is pentobarbital. It is a barbiturate. And it's used for these patients that are in the ICU that are fighting the ventilator or having problems with intracranial pressure because it totally relaxes them and puts them in kind of a barbiturate coma. But the good thing about it is this. There's a reversal agent, Ramazicon, And I can, if the doctor comes in and says, I really want to do my neuro assessment right now, I can reverse it, they can do their neuro assessment, and I can put them right back in it. That's why they choose this drug, because it's reversible. So that's the one they choose.
That's what they use for, like, lethal injections too, to relax them for
Sure they do, you're right. That is what they use.
What was the name of the antidote?
Romazicon. Romazicon.
Romazicon.
And here's your other treatments for increased intracranial pressure that if none of these things work,
I don't know.
you're going to do a ventriculostomy. And this is what I was talking about, the drain that goes in the ventricle of the brain and drains out cerebral spinal fluid. I don't really want you to know anything about how to maintain it or anything. What I want you to know about it in level 3 is, if I stick a probe through their skull into their brain, what else can get in there? Bacteria. So, what do you think about that if the doctor tells you to change the dressing on the ventriculostomy? Sterile procedure. If the doctor says, we're going to put a ventriculostomy in, can you get everything set up? Is the environment sterile? Is it really important that we don't contaminate this? So, that's what I really want you to know about that in level 3. The other thing is a decompressive craniotomy. Has anybody had a patient that had a craniotomy? Did they implant the skull? Yeah. So they can take, wherever the bleed is, they can take a nice big chunk of the skull out and embed it in the client's abdomen. And then once the issue is resolved, they can take that back out and put it back in the patient's head. Same thing here though. The tissue on their brain is, the skin is closed up, so I don't have a piece of my skull right here. And they can live that way for a long, long time. So what I want you to think about with this patient is, if they're up and ambulating, safety. Then most of them will wear the helmet to protect that. I don't want my family, ooh, geez, that skull's kind of cool. Keep your hands off of it. It does look kind of cool. Their whole head's caved in. But you don't want the family to be touching it, so you have some family teaching to do. And what's my risk of infection right here? It's high. So I need to be making sure that I'm using good hand hygiene. When I'm changing the dressing, I'm using sterile supplies, things like that. That's what I want you to think about. Safety and preventing infection. Okay? So, take a break. Come back at the top of the hour, and we'll talk about upstairs. There's no